when you do it long enough, you can see it. But until you get to that point, you've got to think about these things. So when you're teaching your clients how to do this stuff, you've got to, or and your patients, you've got to be able to take that into consideration when putting them in a deadlift position, assuming you're going to try to use deadlifts going forward. And let's talk a little bit about it. I apologize for the 2 typos that are in your handouts. It should be Athrometrx, and inappropriate was spelled incorrectly. My guy told me he did spell check, but obviously he didn't. So I saw it late last night when I was putting these things together, and I apologize. I was able to correct it on slides, but he was running out, he was going on vacation, so these things happen. So Athrometrx is sort of my brand of corrective, prescriptive evaluation and biomechanical evaluation, and then creating exercises to fix that. And what I look at, and what I think physical therapy and rehab, what I look at when I'm treating a patient are these 3 things. Now, we're all good at figuring out tightness, and we're all good at figuring out weakness. But number 3, I think, of them all, is where physical therapy is moving and going in that direction. It's neuromuscular patterning. It's basically what we're talking about. Now, we can list everybody's tightnesses and weaknesses, but I think what we as physical therapists need to do is prioritize that. You know, a good therapist can figure all that out. A great therapist figures out what's driving the system, fixes that one thing that unlocks the 5 other things that you might have found, and fixes those. So our decision making becomes better, and we're able to fix and help our patients more quickly as a result of looking at what's driving the system. Now, I take that term from when I took Stanley Parris's course back in probably 1993. I think his name was Mr. Smith. So that's not a term that I came up with, but I love that term. When I heard that, I said, that is exactly what's driving the system. We might have 10 things going on, but what's the one thing that we really need to fix that's going to fix a lot of those other things? So we assess these things, but when I look at how I'm approaching my physical therapy, I'm doing neuromuscular patterning drills all the time. That's really what my PT has become. And they can go in the gym, get on the bike, and they can go in the gym. And unfortunately, I see this happen in PT clinics where, and I hear patients who I've seen come, well, Rick, I was on the bike, and then they told me to get on the BAPS, and he was drinking his coffee, and then he said, well, yeah, go over to the leg press, and he was texting somebody, you know, and he goes, I didn't think that I could do that myself. I go, you're right, because that's not physical therapy. You could easily do that yourself. What a physical therapist, at least what I see, our role is, well, why is that person not tracking correctly? Well, just to tell them to go and do squats isn't going to help them. So I spend 30 minutes teaching somebody how to do a straight leg raise because they can't fire their quad correctly when they do a straight leg raise. Or 30 minutes on just connecting to their femur so that it can stay in the right place when they're bending. It takes a lot of, I use cueing, I get them to really connect into their glute, the deep rotators, the foot, the positioning of it. If I have to build an orthotic, I do it myself because I'm not trusting the podiatrist these days. So I spend a lot of time on small drill work, and then I go on to my next patient and say, here, now go do your leg press, get on your bike. But my time, I find, is much more valuable, or certainly much better spent on teaching them motor pattern. Because if I change their motor pattern, a lot of the weakness and a lot of the tightness that I see goes away. Okay, so I could, and vice versa. I could spend all the time in the world stretching their hamstrings. But here's a great example. In golf, when are the hamstrings a problem? Does anybody do any golf training or any golf stuff? Or does anybody play? Can somebody just tell me? Oh, don't be all. Can anybody tell me where in golf is a hamstring a problem? Anyone?
In the ball on the ball?
Well, on the golf.
Well, so I see these guys teaching golf, and they're saying, well, when you're in a dress, if your hamstrings are tight, you're going to lose your lordotic position. I said, really? Okay. Well, if I'm here and I can bend this far before my hamstrings get tight, and I'm only asking somebody to bend this far with their knees bent, tell me how that tight hamstring is going to really affect his posture in golf. Well, you know, yeah, in theory and in the book, if you have a tight hamstring, well, it could pull and do this, but that's not reality. That's not happening. There's no way. The last thing I'm going to stretch in a golfer is a hamstring. The guy's slicing the ball, losing 20 balls around for crying out loud, and I see these guys stretching his hamstrings. When the guy can't rotate because they hit the ball straight. So why are we spending time on hamstrings? When the only time a hamstring really plays a role in golf is when you go to pick the ball out of the hole or put the tee in the ground. You're right. So we got to think about this stuff. So is it hamstring just because the guy comes in with a tight hamstring? You know how many good golfers have tight hamstrings? Maybe they're supposed to have tight hamstrings. Right? Think about it. Just because you make your hamstrings loose doesn't necessarily mean you're going to play golf or well. So we just got to think sometimes. I think we need to just look at what's going on here. And yeah, maybe the book says that, but that's not what's going on in reality. So again, if we can get to, and again, if we just work on tightness and weakness and we let that person, perfect example, posture. We can do all of our nice rubber band things and our T exercises and this and that, and then they go home and sit like this for the next for the next 2 weeks before you see them again. We're not doing. First thing I teach someone with a back problem is how to sit correctly. I don't show them any. I mean, I might show them some McKenzie stuff, or if it's a press up or a disc, whatever. But if I'm not changing their position, then all the work I'm doing is not really going to help them a whole lot. So let's think about motor patterns. Rotator cuff again. There's so many compensations that occur to a shoulder problem. When we're not looking at, and this is sometimes when I think we need to look at isolation versus functional stuff. I mean, I like functional stuff, but there's a place for isolating things. There's a reason why they do it. When someone cannot move through their glenohumeral joint with no scapular motion, which on their good shoulder, they can get 90 degrees without any scapular motion. But on their surgical shoulder, it's not happening. Well, that's the first thing I'm going to spend. I don't even work on the rotator cuff. I want them to regain some glenohumeral motion. And the motor pattern to create that, because then when they go up over their head, they're going to have the glenohumeral strength to get the 2-to-1 ratio, so that they got the 2 in the glenohumeral joint, instead of 2-to-1 the scapula pushing the glenohumeral joint. So we need to look at some of this stuff, just from a neuromuscular sense. And a lot of what happens in Olympic lifting is neuromuscular patterns, which is what I love so much about it. We do a lot of drill work to get someone in the right positions. And if anyone has any questions, please, I'm trying to go, this is like a 2-day course that I'm putting together here in an hour and a half. So I apologize if I'm going kind of fast, but please, if you have a question, let me know, because I want to, each kind of concept builds on each other, and I want to make sure you understand so we can move on to the next.